is Abena Appah-Sampong, who graduated with honors from the University of Chicago in 2016 with her BA in public policy and biology. Just a few years after my wife graduated from the University of Chicago. As an undergraduate, Abena volunteered childcare and tutoring services at the Maria Shelter, and after college, Abena completed a public interest fellowship at Cook County Health and Hospitals, where she worked to build infrastructure implementing the health system's strategic plan, and also conducted analyses advocating for the addition of bilingual nursing staff. As a medical student, Abena is the co-director of the Maria Shelter Clinic and serves on the Wellness Committee. She co-organized a conference for Black and Latino women in medicine in the Chicagoland area and was also a mentor for HPREP, a healthcare pipeline program for underrepresented minorities. Currently, she's working with Dr. Neda Laterapong to forecast future racial disparities in diabetes complications using simulation modeling. Today, Abena will present a paper entitled Predicting Lifetime Disparities in Outcomes for U.S. Black and White Adults with Type 2 Diabetes. I'm delighted to introduce Abena.
Thank you, Dr. Siegler. So this was done as a part of the summer research program that I had the opportunity to participate in this past summer. So there are over 30 million Americans living with diagnosed diabetes in the United States, and living with diabetes increases the risk of developing life-threatening complications like cardiovascular and kidney disease. And we also know that racial disparities in the prevalence and complications of diabetes exists. For example, 12.7% of non-Hispanic Black Americans compared to 7.4% of non-Hispanic White Americans have diabetes. Additionally, non-Hispanic Black Americans with diabetes have twice the likelihood of developing end-stage renal disease and are at a higher risk of developing retinopathy. So we know that the management of diabetes risk factors decreases the risk of various complications. So for example, tight regulation of hemoglobin A1C decreases the risk of microvascular and macrovascular complications, and management of blood pressure, cholesterol, and smoking cessation decreases vascular disease and mortality. And additionally, the literature suggests that risk factor control has been improving over time. So we're seeing better glycemic control, more patients are hitting their individualized targets, we're seeing lower blood pressures and lower lipid levels. So with this study, we wanted to ask the question, will these improvements in risk factor control translate to decreased disparities in diabetes complications in the future? So with that question in mind, we had two goals. Number one was to characterize the differences in risk factor control between non-Hispanic Black and non-Hispanic White U.S. populations living with type 2 diabetes in the year 2003 and 2013. And then to also use the type 2 simulation model to forecast how risk factor control is projected to affect disparities in diabetes outcomes and complications over the lifetime. So our hypothesis was that since risk factor control is improving for all populations, the racial disparity in risk factor control between non-Hispanic Black and non-Hispanic White populations living with type 2 diabetes has decreased, and therefore disparities in rates of complication will decrease in the future. So the data set that I used was the National Health and Nutrition Examination Survey, NHANES, in the year 2003 and 2013. So NHANES is a continuous cross-sectional survey that's administered to a nationally representative population. They administer questionnaires, medical examinations, and lab examinations, and it is sampled in a way that allows us to make estimates for the general population. So from NHANES, I was able to construct a nationally representative cohort of adults living with type 2 diabetes. And in order to be included in the cohort, you had to have a self-reported diagnosis of diabetes. You had to identify as non-Hispanic Black or non-Hispanic White. And if you had been diagnosed with diabetes under the age of 18 or started on insulin at the time of diagnosis, you were presumed to have type 1 diabetes and excluded. So in the end, for the year 2003, we ended up with 97 non-Hispanic Black people, which ended up representing 2 million people, 2 million Black Americans in the United States with type 2 diabetes, and 183 non-Hispanic white people, representing 8.9 million people. And for the 2013 cohort, we had 164 non-Hispanic Black people, representing 3.1 million people. Compared to 224 non-Hispanic white people, representing 12.6 million people. And with that, we asked the question, is risk factor control better in 2013 compared to 2003? So the results for this part of the study, within the non-Hispanic Black cohort in 2013, we saw lower LDL levels, longer durations of diabetes, and lower hemoglobin levels. Within the non-Hispanic white cohort in 2013, we saw lower LDL levels, higher A1C levels, lower HDL levels, higher leukocyte counts, and lower heart rates. So the next part of the study was to then forecast how this risk factor control was projected to affect disparities in diabetes outcomes and complications. So we took our cohorts and we ran 2,250 simulations through the US type 2 diabetes simulation model. The model is a patient-level Monte Carlo-based Markov model using validated risk equations in order to predict incidence, prevalence, and mortality related to type 2 diabetes. But it is what I like to affectionately call an Excel-based crystal ball. And the outcomes that we were looking at were rates of diabetes complications over the lifetime, which included foot ulcer, blindness, renal failure, amputation, myocardial infarction, ischemic heart disease, and stroke, and also the remaining life expectancy by year and by race and ethnicity. The significant findings from this part of the study, the 2013 cohort had higher risk of amputation than the 2003 cohort, both overall and between the within the non-Hispanic white cohort. Additionally, the 2013 non-Hispanic Black cohort had a higher risk of end-stage renal disease compared to 2003. So then when we looked at the difference in risk or the disparity, we found that the difference in end-stage renal disease was higher in 2013 compared to 2003. And just to represent that graphically, you can see that the difference in risk and end-stage renal disease in 2013 is wider than in 2003. So the study has a few limitations. We utilize self-report data for our analysis. NHANES is also a cross-sectional survey, so elucidating trends over time can be difficult. And the model equations were built using a binary Afro-Caribbean versus white variable for race. So we could only analyze data from these two racial subgroups, and the relationships for Afro-Caribbean may not be the same for African American. So our study implications, and suggests that risk factor control for type 2 diabetes may not be improving over time for either non-Hispanic Black or non-Hispanic white populations. We also projected that the disparity in risk of developing end-stage renal disease was higher for the 2013 cohort compared to 2003 cohort, which was unexpected. And this is not, a great finding given the rising prevalence of diabetes and increasing burden of kidney disease. So I'd like to acknowledge all these people, especially Dr. Laitirapong, and of course, the Bucksbaum Institute. Thank you.
That was a beautiful presentation. Thank you very much. What are your ideas related to why those failures didn't?
Yeah. So that's the next part of the study, is having to go back into those risk equations and see what covariates were the most important. I think that from what I've seen, the estimated glomerular filtration rates changed, which is a problem. And then it also might be hemoglobin levels, which I'm not sure what the clinical correlation of that is, but that's another significant variable that changed that seems to be important.
Thank you so much.